what I'm going to do is really start in terms of neuroradiology, and in particular, I think these are the three key areas that are fair game for the 2B examination. And in particular, it seems all-encompassing: brain, ventricles, CSF, and vascular supply. But if you think about the way the exam's formulated, it is looking at people recognizing common things in unusual presentations, or slightly unusual things, but being formulaic about it. And in terms of the brain, if we look from a 2B long case point of view, you're going to have a case which is layered. So the most common presentation in terms of neuroradiology tends to be infection, where you have a plain film of the the midface. So you have a unilateral opacified sinus, and then they go on to have a CT scan of the sinuses, which shows quite extensive sinusitis with bony erosion, permutative change, and then potentially an MR that comes in afterwards, which shows extradural spread, potentially meningeal involvement, and a cavernous sinus thrombosis or a dural sinus thrombosis. And that tends to be the linear way in which the long cases project. There's always something on each of the imaging, but they should add a layer of complexity each time. And your challenge really is to identify the key findings and then work through piece by piece on actually, what am I expecting to see next? And how am I going to tackle this? In terms of the viva, it really does depend on the case that's been selected. They tend to be cases that are slightly common, but testing for students or testing for candidates. And also the cases themselves will be very much, they'll have been checked. So you're not going to get anything weird and wonderful. And it will be in the realms of malignancy, infection, and items such as the vasculitides, etc., in the head and neck. But in terms of the brain parenchyma, that's where really the other things that come in are your understanding of MRI, and in particular the sequences and when to request certain other sequences, and your use of resources. Because certainly in my experience with the Viva previously, was it really wasn't limited to just pure pathology and rote accounting for, there's three differentials for this and bang, bang, bang. Actually, it was a little bit more, talk me through the anatomy of X, or please show me Y, or what would be this next sequence you might want to choose? What would you expect to see on that sequence? So the examiners may move laterally as well as vertically through some of the questioning. And I think, I hope today we can tackle some of that. And then don't forget that the brain parenchyma itself is surrounded by, obviously, the CSF and the ventricles. And so we have to think about intra and extra-axial masses, which we'll discuss. And then finally, the vascular supply. I think we spend a lot of time discussing the weird and the wonderful. And in the Vivas, things like stroke will come up. And it's important not to kind of walk past what you think is common, because we're doing it day in, day out, in order to prepare for some of the more bizarre neurocystosarcoses, etc. So I've started talking about the neuroradiology itself, and what I want you to think of is this is what you're going to be seeing on a say a lateral view, but also on your CT. And as you know, the neurocranium is surrounded by the calvarium, which is made up of a number of bones, most of which are paired, and then you have the midfacial skeleton. And as you dissect that down, you've got the strong dural layer, then you have the subarachnoid layer, the pia, and then you have the brain parenchyma itself. And that's surrounded and bathed by CSF, and also you have the arterial supply coming up from the great arteries via the internal carotid system, and also the basilar system, or the vertebrals, and then the venous drainage itself. And so the pathology for all of that is much the same as that you would see in the rest of the body. It's just the soft tissue is different. But in terms of the primary malignancies, etc., it's bone, it's fat, it's connective tissue, or it's you're going to be looking at the brain parenchyma itself. In terms of complications, it's thrombus, the same way we get a DVT, a superior sagittal sinus thrombosis. Same way you're getting embolic events as a result of mesenteric ischemia, etc. You're going to be getting stroke. So all of that is really just an extension of systems elsewhere. And I really hope that by the end of this, you'll feel a little bit more confident in extrapolating that way. So this is a kind of a cut section through the skull, and it shows you that you have, and I don't know whether you can see it on my pointer, and I hope you can, you have just some basic anatomy in terms of the anterior cranial fossa. Now, obviously, the anterior cranial fossa supports the frontal lobes, and you can see here quite nicely that you have the olfactory bulbs, which are lying along the cribriform plate, and here you have the crista galli. Then you have a very thick layer of investing fascia, the dura, which is lying on top of the sphenoid. And bilaterally, here you have the optic nerves that are going into the orbit, and this really signifies the start of the middle cranial fossa. And I highlight that in particular because the skull is really just a Lego set of gradients coming down. And so diseases in the anterior cranial fossa are very reasonably easy to see in terms of on CT and in terms of on MR. The middle cranial fossa, if you like, is the workhorse. You've got the temporal lobes and also the vast majority of the parietal and frontal lobes radiating backwards. And then you have the posterior cranial fossa, which lies below the tentorium, and it descends down towards the foramen magnum. And as you can see, you've got the vascular supply coming up and all of the cranial nerves, which are coming from the base of the brain and heading out of their respective foramina. Now, I highlight this because the posterior cranial fossa is very difficult to appreciate on CT. So in terms of gamesmanship and what you should be thinking of when you're presented with a case is, if you're looking at something that seems to be arising from the posterior cranial fossa, then it's going to fit into a pattern of, is it a child or is it an adult? And actually that's the approach for all of your brain tumours. But also, what could they be asking me in the posterior cranial fossa? Well, really, they're going to be looking at things like cerebellar pontine angle lesions. And then you think, right, okay, well, there's only really going to be three main ones. How do I differentiate between these? If they're looking in the middle cranial fossa, you're starting to think about, okay, is this a parenchymal lesion or is this an extraaxial lesion? How do I differentiate? And in terms of the anterior cranial fossa, remember, you've got obviously the frontal lobes, but this is much more susceptible to trauma, for example, or infection that's coming from the frontal sinuses. So I think in terms of challenging yourself for the 2B, a lot of it is turning your thinking around to being not actually what am I thinking of at work, but what am I thinking can be presented today. And that's actually, I think, quite a good way of approaching the exam sometimes. Tailor your differentials, not just to the age of the patient, but the anatomical location where it is. How does this relate? And is it a common finding or is it an atypical finding? And I'm going to draw your attention here. So in terms of sequences, this is obviously an MRI scan. And I think the first thing to just be wary of is spending some time with colleagues and spending some time when you're looking at sequences to work out why a certain sequence is what it is. And I say that slightly glibly, but when you're stressed, looking at a T1 weighted axial image of a brain and a flare sequence, when you've been used to just saying, actually, it's T2 because the globes are bright, which has got you out of trouble year in, year out, is going to get you into trouble that way. So actually start thinking quite carefully about the sequences you're being shown, because when you're under pressure, and remember, none of us spend only 5 minutes looking through the whole neuroaxis on an MRI scan. But when you're under pressure, you will say things that you look back and really wish you hadn't, and we've all been there. So the first thing I think is you need to be really comfortable in the sequences that you commonly will be expected to see in neuroimaging. I suspect all of you are very confident in looking at CT brains and deciding what is normal, what is abnormal, what is interparenchymal bleeding, what is subdural bleeding, and what is subarachnoid bleeding. But once it comes to neuro, it becomes slightly more difficult. So the first thing I think before we even attempt any of the pathology is to be really clear, okay, can I differentiate T1 from flare, Can I differentiate blood products on T1 and T2? And fundamentally, can I age blood products on T1 and T2? How do I know if something is contrast enhanced? And the get out of jail all the time is not necessarily looking at the vessels, but looking at the mucosa of the nose and the sinuses. And also, what would be the next best sequence? Because in clinical practice, we're presented with a number of different sequences, and we have the luxury of time and also sequences to put a picture together. In the exam, you have neither of those luxuries. And I'll give you an example. In one of my fibers, I had a epidermoid cyst at the cerebellar point angle, and what they wanted to know was what would be the next sequence that I wanted, and that they were looking for diffusion weighted imaging, or ADC, and what the imaging characteristics would be. Now, they didn't show me that imaging because I answered the question already, but that's the sort of thing they're looking, your preemptive lateral thinking on how this is going to go. And just looking at this posterior fossa, which I've chosen this slice for, as you can see in terms of the anatomy, this is where all the major cranial nerves are coming out effectively as you're coming up the brainstem into the midbrain, so that where the pons is meeting the cerebellum just before it's going up into the midbrain. But in terms of exam gamesmanship itself, you're then thinking, okay, what could be the three things that are going to arise around here? Well, number one, it could be something that's rising from the internal auditory meatus and running along the nerves. So you'd be thinking acoustic schwannoma. You could be thinking, number two, is this going to be a meningioma? And number three, epidermoid, as I mentioned. So in terms of trying to work out what are your set pieces, we all talk about, okay, well, you should be able to rattle off cavitating right upper lobe masses, or left lower lobe collapse. But my first kind of tip for you would be for neuro is there are set pieces in neuro. You're always going to see something. So the top three differentials in the cerebellar pointile angle strikes me as the first one. How to differentiate something from intraaxial to extraaxial. A posterior cranial fossa mass in a child. What should you be looking for next? Well, is it isolated, or is it part of a neurocutaneous disorder? Neurofibromatosis, etc. Always try and start thinking, what are the set pieces that I might get shown in neuroimaging? And again, looking at a sagittal of the MR, and I've given you the anatomical, primary pictures, anatomical slice through. This is almost a given to some extent on one of you will get this sequence in the long cases because it works very nicely, and sagittal MR is a particular favorite. And you're going to be looking at things like the dural sinuses, so a mastoid infection. Remember, mastoiditis is a clinical diagnosis, but if someone has the clinical history would be, redness over the mastoid process. You look through, you can see that the mastoids are unilaterally opacified, and then you start looking at the bone windows, this permeative change, and they've got malignant otitis externa, for example, in an old person with diabetes. Just think of the kind of red flags. And then start thinking, well, what's going to be happening next? Is there intracranial extension? Is there a complication such as a venous sinus thrombosis, which was a case, again, I got in the long cases. And what is the complication then of a dural sinus thrombosis? What am I looking for next? Well, should I be looking for a venous infarct instead of an arterial territorial infarct? So always trying to think one step ahead. Again, set pieces within the neuro system.